question on it on your survivors or even in your long case, especially on the adult path, you will encounter orthopaedic oncology questions somewhere in your exam. And I think it's just general principles that you need to demonstrate at the level of the FRCS exam rather than specific knowledge about tumors, other than some of the common ones. So we will go through some of the common tumors, but we will also speak about the general setup of the UK orthopaedic oncology practice, which is quite important to know when you're tackling those questions. So we'll be sort of talking about the common bone and soft tissue tumors. We can't obviously discuss all of that. We conduct that as a 3-day course, and even then we find time is not enough. We'll also talk about some of the benign tumors, as well as going on to see some of the malignant tumors on the spectrum. There are obviously intermediate grade tumors as well in between the two. We also need to discuss early identification, prompt investigation of these tumors, and then the treatment options available for some of the common ones. The way the UK sarcoma network is built is that there are, and I'm sorry for my Scottish colleagues here, if there are any. This map is just looking at England. So we have well, essentially 5 centres. This slide is a bit old because Oswestry at that time had gone a bit redundant, but they're back now. So we've got Stanmore in London, then we've got Oxford, and then we've got Birmingham. We call this the M40 chain of orthopaedic oncology centres, and then we've got one in Newcastle. These are the primary bone centres, and these are represented by the triangles. Obviously, Oxford is right in the middle of those two in Birmingham and London. Then we've got the blue dot, the yellow dots are the soft tissue sarcoma centres, and the distribution is such that there are more soft tissue centres, and that reflects the incidence of these tumours. So there are more soft tissue sarcomas that you would see. The ratio is roughly 5:1. And that's why you need more centres doing soft tissue sarcoma work with local oncologists and local MDTs, whereas the current requirement for primary bone work is not as much. So in Oxford, we've got a catchment of about 10 million. I think London is definitely bigger than us. I think they see about 1 million. Then Birmingham is probably the biggest unit, not just in the UK, but also in Europe at present. So in terms of the workload, especially after Oswestry had paused for a bit, and then all of the patients from Wales and west of England were coming up to Birmingham as well. But anyway, so these are the specialized tumor centers where you are expected to refer your patients if you're working in the DGH or in any of the catchment areas. So London looks after the southeast, we look after the southwest, and then Birmingham looks at all of the Midlands, and then Newcastle looks at the north of England. In Scotland, they've got 3 centres, one in Aberdeen, one in Edinburgh, and one in Glasgow. Okay, so what's an MDT, and what configures, what do you need in it? So just to give you an example of what the orthopaedic oncology MDT in Oxford is like. So we are one site MDT for sarcomas from head to toe, not just orthopedics. We have got orthopedic oncologists, plastic surgeons, sarcoma oncologists, histopathologists, different surgeons according to regions. We've got cavity surgeons, including thoracic surgeons, as well as abdominal surgeons. We also have maxillofacial surgeons sign in if they have cases, and then we have pediatric oncologists as well for our pediatric and teenage and young adult patients. We've got cancer data managers. We've got actually we have now 4 nurse specialists, and we obviously are ably led by an MD coordinator. The way the referral system works is we have a referral pathway. Patients are referred on the 2-week wait pathway. They would or they might or might not have had all the imaging. And there's a triage service which triages the patients. They get their scans. We try and do a one-stop clinic where patients come in, have their biopsies, and then they go on to MDT. Sometimes you would have a referral with a biopsy done elsewhere at a DGH, who are referred with the pathology results. Then they go directly onto the MDT, where all these people obviously discuss, the patients and their presentations with the imaging and the pathology results. So obviously we are bound by some targets. There's a 62-day target from referral to treatment, and then there's a 31-day target from diagnosis to treatment. And obviously there's a fine if we breach those targets. So we are quite a time-bound service, and once the referral has been made, clock work starts, and we have to get treatment initiated within those timeframes. Now let's talk a bit about sarcoma, which is why you're here. It's a very rare malignancy, as we all know. 1% of all adult malignancies, 15% in pediatric patients, 60% of those occur in the limbs, including the pelvis. Lower limb is very common as compared to the upper limb, but you can have some occur in the trunk. We do run a retroperitoneal sarcoma service here in Oxford, and we also run a very good thoracic sarcoma service here. There are many different histological subtypes. You don't need to know all, but you need to know some of the common ones. Now, where do they arise from? We know that sarcomas arise from mesoderm, which is the middle layer of the three germinal embryonic layers. And those layers, obviously, that middle layer makes up all of your connective tissue, your muscles, your muscles, and your skeleton as well. The spread through this layer is all hematogenous, and that's why most of the sarcomas would metastasize to the lungs in the first instance, rather than the lymphatic spread, which is mostly seen with carcinomas, because they've got a lymphatic drainage. Now, there are different types of histology. There are three general types of histology. You've got carcinoma, which comes from the spindle cell layered tissue that look like lining epithelium. Then you've got hematopoietic tumors, which have little stroma around, and you've got a lot of hematopoietic pluripotent cells in it. But then sarcoma, again, spindle type, stromal, cigar-shaped cells, and that's the general feature of the sarcoma. Just to show you some slides. So, as I said, soft tissue sarcomas are 5 times as common as primary bone tumors, and that's why that's reflected on how many centers we have around the country with the problem. Sarcomas, the bone will depend on the type of tissue that the sarcoma will be producing. It could be cartilage-producing tumors, bone-producing tumors. Obviously, you can then have muscle tumors when it comes to soft tissue sarcomas. Fat tumors, and then smooth muscle tumors, and obviously the names go with chondro, osteo, rhabdo, lipo, and leiomyo when it comes to smooth muscle. I'm pretty sure all of you know that nomenclature. But every tumor type has got a separate biology, and that's why we are so dependent on histology to guide us. So when we talk about bone-forming tumors, there's a benign variety, which is an osteoma, or you could have an osteoblastoma. But the malignant variety, which is you see this classical osteoid, which is the pink eosinophilic material, fairly acellular, interposed between the cells, which gives the cells have to be atypical as well. Whereas you can see in the first slide, the cells are very well differentiated. You can see only singular nuclei, whereas you can see pleomorphic nuclei in the second slide. So that's a malignant osteosarcoma on your second slide. When we come to chondrosarcomas, it is mainly by virtue of the cellular density, how we differentiate chondromas from chondrosarcomas. And then you have enchondromas, when the chondromas are intramedullary, and you've got exostosis or osteochondromas when they're extramedullary, but they are part of the same benign pathology. Slightly different in terms of their genetic subtypes, but that's probably beyond the realm of this one review talk. But then when we come to chondrosarcomas, you will have that cartilaginous matrix with a lot of atypical looking chondrocytes, but the cellular density is pretty high. The grade itself will depend on the cellular epithelium or the nucleolar pleomorphism, really. When we come to lipomas, again, benign lipomas are fairly bland with those wide vacuoles, not many cells there, whereas liposarcomas will tend to be very, very cellular. with still some fat vacuoles around. And that's what differentiates lipomas from liposarcoma. Just a quick point out about liposarcomas. When you see retroperitoneal lipomas, they tend to be liposarcomas mainly, or probably low-grade liposarcomas. You always stage 1 up. And that also goes for cartilage tumors. When you see them in platforms, such as the skull, scapula, or pelvis, you always upgrade it by 1 grade, regardless of what the pathologist says, because that has a direct impact on how you treat them. So a lipoma in superficial tissue on the limb can be left alone, for example, but a lipoma that's coming from the retroperitoneum will just grow and needs to come out, not just because it's benign, but it can transform into liposarcoma over time. Now, when you come to fibrous tissue, obviously there's fibroma, there's histiocytoma, and then there's fibrous dysplasia, whereas the malignant subtypes are fibrosarcoma and the undifferentiated pleomorphic sarcoma, which in the past used to be called the malignant fibrous histiocytoma. However, WHO revised that in 2014. The nomenclature was revised, and now the current name is undifferentiated pleomorphic sarcoma. Again, benign, you've got leiomyoma, you've got smooth muscle spindle cells, not looking very atypical, but as you see on the second slide, the nuclei are bigger, they're atypical, they're pleomorphic, so it's a higher grade tumor, and that hence it is called a leiomyosarcoma. And similarly, in pediatric age group, you've got rhabdomyoma and then rhabdomyosarcoma. You can also have other connective tissue tumors. You can have tumors coming from blood vessels. You can have hemangiomas, lymphangiomas, and then the malignant variety would be angiosarcoma. Similarly, within connective tissue and extremities, we have nerves besides the vessels, and then you can have schwannomas or neurofibromas, which can present as part of NF1 or NF2, and then the malignant variety would be a malignant peripheral nerve sheath tumor. Again, it's based on histology, histological appearance of the cells. So, what has changed in the past, say, 4 or 5 decades is a lot in orthopedic oncology. Obviously, one of the aspects is the pathology and how we look and diagnose things. It's not just plain microscopy, as my colleague on that picture, Professor Nick Athanasiou, has well published. Now we are working towards obviously gene-based diagnosis. There are a number of gene translocations that are read, and obviously prior to that was immunohistochemistry, which is still done. So it's not just cell morphology, it's immunohistochemistry and then cytogenetic analysis look for certain translocations. There are a number of immunohistochemical markers for different cells, and that's what aid in diagnosis. And that can actually change the diagnosis so drastically sometimes that your whole treatment protocol might be affected due to the immunohistochemical results. For example, certain lipomas, which you will excise thinking they were lipomas, but they will come back as positive for certain immunohistochemical markers, and then you need to follow them because there's a high rate of recurrence. I'm not going to speak about all of the histochemical markers because it's useless for the FRCS level, especially for orthopedics. But you need to know some of the chromosomal translocations, especially for Ewing's and synovial sarcoma. I think Ewing is probably the one that you will come across in the exam, which is the 11-12 translocation or the EWS1 gene. So I think that's one thing to remember, not just for your MCQ, but also for your exam, because you might get a Ewing sarcoma-based question. The 3 commonly asked are Ewing sarcoma, osteosarcoma, and chondrosarcoma. So those are some of the chromosomal translocations. But there are so many translocations that we can't really discuss them in a single talk. Now, obviously, sarcomas occur across a range of age. You've got pediatric sarcomas and you've got adult sarcomas. Generally, you've got rhabdomyosarcomas in soft tissue tumors, and then Ewing sarcoma in the pediatric age group if you come to primary bone pathology. In young adults, you get osteosarcomas. You can again get Ewings, but however, chondrosarcomas tend to be in older age group, after the 50s and 60s. But young adults up to the age of 20, 30, mostly see osteosarcomas So there are three main treatment modalities for any cancer, as you know: surgery, chemotherapy, and radiotherapy. And obviously, treatment is dictated by what tumor you're dealing with. We know that, for example, chondrosarcomas are completely radio insensitive and chemo insensitive, and hence surgery is the mainstay of treatment. However, myxoid chondrosarcomas have got some radiotherapy susceptibility. Extraskeletal variety has got some radiotherapy susceptibility. There are some trials going on currently to assess efficacy of certain immunotherapeutic agents for metastatic chondrosarcomas. When it comes to osteosarcomas, there is a well-known osteosarcoma regime with VDE chemotherapy. You would typically get 2 to 3 cycles of chemotherapy, followed by surgery, followed by further chemotherapy. The margins are closed, but if there is, paucity of response chemotherapy, normally you're looking for 80% response to chemotherapy. If not more, a 90% response is associated with a much better outcome as compared to 80%, but you're aiming for an 80% response to chemotherapy on your resected post-chemotherapy sample. So that's what to do with osteosarcomas. Ewing sarcomas has got its own protocol, which is according to the Euro-Ewing trial, which is something you can quote on the exam. Treatment is based on the Euro-Ewing trial. The other thing you can also quote for Ewing sarcoma is that's the only sarcoma that has a national MDT, which happens every fortnight. So all of the centers are bound to discuss their Ewing sarcomas on the national Ewing's MDT. You can, if you don't want to, it's not compulsory, but all of the difficult ones go to the national Ewing MDT. It is supposed to be, all Ewing sarcoma are supposed to go there and then have a discussion with the experts on what should be the regime. But anyway, generally the regime is they are radiosensitive and chemosensitive, so they would typically have 3 months of chemotherapy plus minus radiation and then excision if they can. There is a growing trend to treat with definitive radiotherapy, especially sarcomas that are difficult to detect either in the spine or the pelvis or the sacrum. They can be treated with purely radiotherapy as a definitive modality. There is obviously a role of proton therapy as well, which is again radiotherapy, which is a little bit more targeted, I would say. So this is just in a nutshell, because this talk is not on specific sarcomas, and I'm just trying to give you an overview. So in a nutshell, those are the 3 things that you would be asked most commonly: Ewing, osteo, chondro. Anyway, so again, they can happen anywhere in the body, and then there's the specific surgeon will be required to look at where they are in the body. Sometimes, if they're in hand, you've got plastic surgeons doing them. You might require an upper limb surgeon or a lower limb surgeon. In Oxford, we've got 3 different tiers. We've got an upper limb sarcoma team, we've got a lower limb sarcoma team, and we've got a pelvic sarcoma team. But then we've got obviously a thoracic sarcoma team and a retroperitoneal sarcoma team, where all of us, the general sarcoma specialists, would sort of work with them. We are well supported by our plastic surgery colleagues for joint approaches. We are well supported by our vascular surgery colleagues, as well as our urologists and colorectal surgeons for pelvic sarcoma. Now, most of the case presentation is pretty simple. They will present with a mass, which has been enlarging plus minus pain. So those are the only 2 complaints a sarcoma patient will present with. Could be a bony swelling, could be soft tissue swelling. You have to differentiate pain, which is biological, versus pain that is mechanical. So pain on activity would be mechanical pain. Pain at rest would represent biological pain, and that is a function of the cytokines that are being produced by the tumor, which essentially are causing the pain. Now, it could also present as an incidental X-ray finding. A lot of chondrosarcomas present that way. Proximal humerus is a favorite site for chondrosarcomas, and a lot of patients are referred after they've had an incidental pickup of chondroid lesion on a routine chest X-ray, for example. They could also present upfront with a pathological fracture. Metastases normally do present with pathological fractures, but sometimes primary bone lesions can also present with fractures. Or in the pediatric age group, you can present with a limping child. One of the rare diagnoses you can quote is a sarcoma. But the importance of the history and clinical exam is, obviously, I can't say more about, and then high index of suspicion when you're looking at the clinical picture as well as the x-rays and imaging of the individual. So the 10-year survival currently to quote on an exam question would be between 50 and 60%. I think a lot of people do quote higher numbers. That's specific for osteosarcoma. We look at 70% 5-year survival, but that's in the ideal world. Generally, all of the centers are experiencing something about 60% 5-year survival on their data. I think survival has not changed much ever since the new adjuvant chemotherapy was introduced back in the 70s and late 70s, and then 80s. We started seeing an improvement in the 5 to 10 year survival. But yeah, that's sort of the figure to quote. So in the UK, well, the size, UK tumor size at presentation is definitely more than 10 centimeters when they present to us. But yeah, I mean, it varies across different health systems and their referral mechanisms. I think in the UK, there's been a lot of work in early referral. We know that every 1 centimeter increase leads to 5% for survival. So all of the sarcoma awareness work we do is based on improving awareness, not just in orthopedic surgeons, but in general practitioners and other specialties who would then need to make a great referral to us. There's definitely a problem with delaying diagnosis. As you can see, I mean, a lot of people would miss that there's something going wrong on the proximal femur here. But anyway, the DGH surgeon who saw this patient with mid-femur or mid-thigh pain recognized that there was something wrong in that proximal femoral area and decided to go for additional pathology. This patient had been long being seen in the sports clinic and being treated for thigh strains and sprains for a number of months before somebody decided to do an X-ray, which is also very common. What happens to these patients? And then somebody decided to get an MRI scan, and lo and behold, there was this large soft tissue mass next to the proximal femur. And you can see, how important it is. So cross-sectional imaging is a modality that you need to use fairly regularly. And this is the tumor that was resected. I can't remember the histology on this one, but yes, that's the treatment: wide resection and replacement. I believe it was a chondrosarcoma, but then the patient had very early pulmonary metastasis and died 6 months later. But you could imagine that, for the tumor to become that large, it would have taken a considerable period of time, and early referral was what was required. We never know, the patient could have had, a better survival than what they had. So I think one of the biggest problems in all systems, in all health systems, and this is not uncommon in the UK, by the way, a whoops procedure. We have, in the last year alone, have had 2 amputations because somebody nailed a chondrosarcoma. We've had transverse incisions by our dermatology colleagues trying to excise what they thought was a lipoma on an ultrasound and ended up being a sarcoma. That happens very commonly. We have sometimes transverse scars on limbs, again, by untrained professionals. Although all of the awareness drives are leading to a decrease. We do a lot of teaching in Africa. In fact, I'm going to Kenya next week. So yeah, we see this very commonly in those countries where there's absolutely nothing. There are no trained oncologists or even general surgeons available to a lot of population. But yes, in a developed health system as we are in the UK, we don't see it that much now, luckily. But I think that's what we need to reduce. So again, the reasons for unplanned excision, there's a number of papers on that. It's because, one, it's a rare diagnosis, so index of suspicion is not very high. The referral guidelines would not be known, so it's good to know the referral guidelines. Guidelines exist. There's nice guidance on referrals. either the reason could be inadequate assessment, and then you suddenly come up with a whoops lesion. So when and who should refer, and how should the referral happen? So just to give you the figures, so 19 to 53% of new patients seen in sarcoma clinics actually end up having a sarcoma. It's a wide variety of, it's a wide number, it's a wide range of percentage. The reason that the percentage is wide, even in the UK sarcoma centres, we've got a slightly different triage criteria. And currently we are seeing smaller number of patients being diagnosed in terms of percentage because the referral rate has gone up. So people are referring things to us that are very benign. So we would say, the percentage of picking up sarcomas is decreasing, but then that's a function of the total number of referrals. The total number of referrals are going up. The percentage of sarcoma is probably the same as a function of the population. So the oldest guidelines were the Department of Health guidelines published in 2000 that called for anything more than 5 centimeters, that's deep fascia, to be referred. I think that still stands, and you should think that that's malignant until proven otherwise. Then obviously Rob Grimer, one of the yesteryear surgeons from Birmingham, who recently retired, I think about 3 or 4 years ago, he published his work with the journal practice, where it was quite interesting. He gave all of the GPs surrounding Birmingham this keychain, the golf ball on, with this pamphlet to say any lump bigger than this golf ball, you need to refer to us. I think that has led to a much better pickup rate. That's been shown in this publication. Now, you see the breast cancer, they ask you to refer on your routine mammograms anything more than 2 centimeters size. So I think we are still further away from that 2 centimeter mark, but I think if people are referring things up to 5 centimeters, that's still good. We need to probably set the bar a bit higher once we get adequate referral rates. Coming to how you diagnose, so you need to look at the age, the site, and then the appearance on an X-ray. And we'll do that in some of the vivas. So age, again, we spoke about how in a young adult you will be looking at, in pediatric you will be looking at Ewing, in older group you will be looking at chondro, and in young adults you'll be looking at osteo. And obviously the site, whether it's epiphyseal, whether it's metaphyseal, whether it's diphyseal. Ewing sarcoma can be diphyseal, for example. Chondrosarcomas can be metaphyseal if they're arising in the background of enchondromas or osteochondromas, but they can be surface chondrosarcomas as well. And you need to look at the X-rays as well to see what the tumor is doing to the bone, or the bone is doing to the tumor, and then what is the periosteum doing. So you need to look at the periosteal reaction, and then obviously what the soft tissue is doing around it. Is there a big soft tissue component or not? So, for example, look at this picture. So this distal femoral X-ray, you can see that there is a lesion over the distal metaphysis, which is eccentric. There seems to be a soft tissue component with some calcification around it. So there are all the features of what you can think of as a malignancy. You can also see that there is a slight periosteal reaction here with a slight Quadman's triangle. You see an interrupted periosteal reaction. A very good word to use in your exam, in your viva, is interrupted periosteal reaction versus an uninterrupted periosteal reaction, or a solid periosteal reaction, which will denote that you're thinking, is this a fast-growing pathology or is this a slow-growing pathology, which will differentiate your benign versus your malignant tumors, rather than using onion skin or sun ray appearance, which is what a lot of people tend to do. But anyway, if you use that, that's also fine. So if you look at the MRI scan, so again, another example, you can see the proximal humerus. There's a very permeative lesion in the proximal humerus, which is destroying not just the cortex, but also intramedullary area. You don't see a lot of soft tissue component around it. Then you can talk of the differential diagnosis. You can think of anything depending on the age of the patient. For example, in an older patient, this would statistically represent either a metastatic lesion or myeloma. But in a younger patient, you can think of fibrous dysplasia because you don't see a large periosteal reaction. So you say that, yeah, this could be something that's a little more benign rather than very aggressive. So coming back to some of the examples, this is a large area in the metaphysis.
So this is radiograph AP view of what to me most probably like skeletally mature or an older adult, because I can still see the physeal scar. I can see that there is a single lesion, lytic, that is well defined with a narrow zone of transition in the epiphysis. So there is no preosteal reaction, there is no soft tissue extension. I would like to know more history about the patient.
That's fine. We're not doing a viva. Just
okay.
Tell me what we'll do the viva later. So just tell me what is your differential? What's your extra differential?
I was thinking of, because it's epiphyseal, I was thinking about chondroblastoma and
yeah. That's what it is.
Yeah. Okay.
Okay. Let's see another example. Does someone else want to talk about this?
Yeah, hi. This is a plain radiograph of pelvis with both hips. I think it shows a lesion on the right, greater trochanter. The lesion is lytic to appear around the head, the neck, and the trochanteric junction. It has a narrow zone of transition, and the matrix appears cystic with possible septations in the middle, and the cortex does not show any interrupted periosteal reaction. I think this is my first differential would possibly be a fibrous dysplasia, and the second would be anything.
That's a differential.
I don't know the second differential.
So yeah, this one caught us actually by surprise because yeah. What do you think? What else could this be?
Oh,
there's another epiphysis here, right?
Yeah. Yeah. It could be a bone, a unicameral.
So this was biopsied actually, and it came back as a cartilage tumor.
Right.
And initially we thought, yeah, this came back as a cartilage tumor, and then they thought that this was a chondroblastoma again.
Right.
So they ablated it.
Okay.
Didn't work.
Mm-hmm.
Patient still had pain, so somebody went and curated it, and it came back as a clear cell chondrosarcoma.
Ouch.
So that's an important lesson here. The reason I put this case here was the important lesson is in cartilage tumors, biopsies are not a very good modality because they're so heterogeneous. It depends on where the needle is going in.
Sure.
And you might not sample the atypical cells, and you might actually sample a completely benign area.
Right.
So even histology can be wrong. But anyway, beware of the clear cell chondrosarcoma because that is a differential of your chondroblastoma. So even the previous slide could have been a clear cell chondrosarcoma. And that's one of the differentials you can mention. When you pick up a chondroblastoma, as you said, Joseph, you say, that's my first differential, but it could be a malignant lesion such as a clear cell chondrosarcoma. You say that, and that gives you so much more on your score, because then you know that this is my pitfall, right? Okay, let's go ahead. So yeah, that's what it was. So again, this is a fairly diffusal lesion in the fibula, and you can see that that's what sort of periosteal reaction is that?
Interrupted.
Interrupted. Hair on end appearance. So again, that was an osteosarcoma of the fibula. Although you can see that the physis is open, so you could say it could be Ewing. You could still say it could be Ewing, but normally in Ewing you would see a laminated, much slower interrupted, still interrupted, but a much slower periosteal reaction. Anyway, so I think from the outset you're trying to get an anatomical, clinical, and pathological diagnosis. That's what you will be expected to do. What investigations? You will do local staging and systemic staging. Local staging with X-rays, MRI, and a biopsy, which will give you the histology grade and systemic staging with either a chest X-ray CT or bone scan combined, or a PET CT. In Oxford, everybody does a PET CT. You need to know, for example, if you're going to say, I practice in XYZ area, we've got Birmingham as our referral center, and this is what they do. By the way, Birmingham does whole body MRI scans, imaging modality for systemic staging. But yeah, PET CT is a gold standard, CT test and bone scan is a gold standard. You can mention those. So yeah, this is what we do, which is a nice color for imaging. Then what the staging allows you is a prescribed treatment plan. It goes to the MVP. You can determine prognosis, and then you can discuss local control and systemic cure. Staging also helps you if they have got widespread metastasis. You can include them in a trial on some of the new modalities, and then compare your experiences with other centers. That's how standard imaging is done. So local staging should be done with imaging the whole bone, because you can have skip lesions. So you need to image the whole bone. If you've got a distal femoral osteosarcoma, you need to image the whole bone. And then obviously, when you plan a biopsy, you need to take images of the biopsy as well, just to make sure that you've sampled the correct area, or your radiologists have sampled the correct area. I'm not going to go through the biopsy principles. This slide was put in this talk because it was for a lower level than you guys. You all know the biopsy principles. Open has got 95% accuracy. We've got 85 to 90% accuracy in needle biopsies, which is the gold standard now. So image-guided biopsies. For bone, you will do fluoroscopic or CT-guided. For soft tissue, you will do ultrasound-guided biopsies. There's no space for FNA anymore in orthopedic oncology, so nobody will say FNA. You send the specimen for histology and cytogenetic and micro. If you're suspecting the differential infection, especially in Ewing sarcoma, you would also send fresh frozen tissue. That's the other brownie point you will get on your vivas. You send fresh frozen tissue for whole genomic sequencing. So WGS, that's the new thing you should all be mentioning. That's what I would request. That's how I will request my biopsy. Then obviously the biopsy needs to be planned with in conjunction with the surgeon, so you know exactly what approach the surgeon is going to use for definitive treatment, and you need to go through one compartment and not go through internervous plane or interfascial planes to avoid contamination of two compartments. So yeah, and then obviously excision of the biopsy tract and definite surgery is important. Then we come to the staging systems quickly. Obviously, the oldest staging system was WHO League of Nations, which is not in practice anymore. Anything is also not practiced by any of the UK sarcoma centers, although a question is asked on the FRCS to compare the American AJCC with the anything, which to me is not relevant because nobody does anything anymore. But anyway, we'll talk about the AJCC, which is based on three parameters: its logical grade, the local extent of the tumor, or the size of presentation, and obviously the presence or absence of nodal or distant metastasis. So the TNM classification, less than 5 centimeters for soft tissue will be T1, more than 5 centimeters T2, and then you've got N1, M1, and similarly for bone sarcomas, 8 centimeters. So histological grade will come from the pathology results, again based on cellular atypia as well as the cellular subtype and the cell density and the nucleolar density. And that's how they will tell you the histological grade, which will go into your staging. So we do know that the tumor grows across the path of least resistance. So they will be bound by the fascial compartments or the periosteum if they're intraosseous. Outside that, they will be bound by the fascial compartments or the skin, but they do tend to go longitudinally because there's no path of, there's nothing resisting them from longitudinal. And that's why most of the soft sarcomas are spindle shaped and most of the bone tumors grow within the medullary cavity. Most of the tumors that you would see would probably be 2B, where they are T1 or T2 in size with no metastasis at the time of presentation. They would probably be extracompartmental. Almost all of the 90% of osteosarcomas present at the stage of 2B. So metastasis, again, another thing that you need to bring into the picture. The survival with metastasis is half of what you would see without metastasis. So if you've got a 60% 5-year survival without metastasis, it drops down to 30% if you've got metastasis up front at the time of presentation. Let's go quickly to treatment options. So centralization in specialist center is essential. That's how you get better outcomes because of dedicated teams who treat these tumors. You have to attain wide margins. So what is a wide margin? Can anybody answer from here? What is a wide margin? That is again a commonly asked question on the FRCS. Any hands up?
So wide margin when you remove the tumor and you also remove soft tissue around it as well. So you remove the pseudo capsule and you go more extension, but it is more or less within the compartment.
Okay. Anybody who can improve on that or has a different opinion? So how wide is wide? How much soft tissue? 1 centimeter, 5 centimeter?
Apologies. I would like to retract that. I think wide margin, which is compartmental. You remove the whole compartment, including bone, muscle, and soft tissue.
So how much do you want to remove this? So this is Ewing sarcoma. That is a pre-chemotherapy scan, and that's the post-chemotherapy scan. How much soft tissue do you want to remove?
I will remove any tissue that up to the pseudo capsule. So I think we're going to remove up to the skin.
Which MRI will you base your resection on?
That one is difficult because it's gone up to the skin almost.
Yeah. Well, that's the biopsy tract, I think. But anyway, this is the vessel. That's fibula. That's the neurovascular bundle. If you were to achieve a wide margin on this, that will have to be an amputation, I'm afraid.
Yeah.
But you can see that the soft tissue after the neoadjuvant chemotherapy has gone away. In Ewing sarcoma, the bony margin has to be based on the pre-chemotherapy scan, but the soft tissue margin can be based on the post-chemotherapy scan. Right? The simple answer to a question, how wide is a wide margin, is in pelvis, for example, we talk about 2 millimeter margin. But in the exam, you're supposed to say 1 centimeter bony margin minimum. And then around it, you need to say next barrier to tumor spread. So longitudinally, there is no barrier to tumor spread, but concentrically, there are barriers to tumor spread. So periosteum, fascial compartment, skin, adventitia of a vessel, or epineurium of a nerve. These are all natural barriers to tumor spread. The simple answer to give in the exam will be, I want to go up to the next natural barrier to tumor spread. That's my wide margin. Longitudinally, you would still say 3 centimeters of bone, 5 centimeters soft tissue tumor, but then you can talk about the fascial tail and any soft tissue edema. That's based on the initial scan, and you will get all the points. So any can also devise the resection levels, which is intralesional excision, marginal excision, which is at the level of the capsule, and then wide excision. What we do mostly these days is what we call a wide excision, which is on your left. Is exactly what you said, Joseph. So you still stay in the compartment. You're not going extracompartmental. But if the tumor is violating the compartment, then you include the next compartment as well. And then you go to the margin of that, so the fascial compartment of the next compartment. What Enneking used to do in his days was radical excision, which is what you wanted to say in the beginning, which is remove the whole compartment. That's not practiced anymore because there's no oncological benefit of removing the whole compartment. There's more functional loss. You have to balance function versus oncological outcome when you're looking at these tumors. So what you would do for a low-grade liposarcoma like this one, you will just perform a marginal resection, which is just at the capsule, and your recurrence rates are fine. So yeah, you would be fine with that. So margin is again a very important concept to describe on your FRCS fiver. You would like to go more than 2 centimeters where you can. You might not be able to all of the time. So that's why you say next barrier to tumor spread. It has to be millimeters when it comes to, for example, you want to say the vessel or a nerve, because that will give you function, or that will keep your extremity. That's where you have to keep it in millimeters. However, there's no room for error in surgical resection. If you have a positive margin, that's it. You've not done your job properly. and the patient will have early local recurrence, early metastasis, and poor oncological outcomes in terms of disease-free or metastasis-free survival. So look at that one. Where do you think the margin will be? I can see Syed Shoaib is unmuted. Syed, where do you think that margin would be?
Software is extra compartmental in the scans. So again, the safe zone will be 3 centimeters of bone margin and 5 centimeters of soft tissue margin. But
yeah, so you can see that's the factory compartment, right? That's the septum. So you have to go to that septum on the medial side, and then on the lateral side, you've got that as a septum.
Right.
It is involving both the deep and the superficial deep posterior compartments. So you have to sort of go all the way, probably up to that neurovascular bundle to get a clear margin. You would want to save the posterior neurovascular bundle because that's sort of clear of tumor. But anyway, so I think that was the plan. Try and get up to the neurovascular bundle as a margin. And that's exactly what was done. You can see that that's the neurovascular bundle. At the back, that's the common peroneal nerve, and that's the tibial nerve going along the vessels into sort of the deep compartment. That, yeah, we got then plastic surgeons to cover that. There's another example of high-grade medullary osteosarcoma with a large soft component treated with a resection and endoprosthesis, which is obviously the mainstay of bony reconstruction in the UK. We can also talk about biological reconstruction, but that's how it was resected and reconstructed. So what has changed really in the last, let's say 5 to 6 decades of oncology practice is, so around 1983, survival started going up. That was a function of chemotherapy. I don't think surgeons have had anything to do with that survival. It's just chemotherapy and improved oncology care for these patients. However, what orthopedic surgeons have done is we have improved the function of these patients. We've now got improved prosthesis, we've got segmental prosthesis, we've got the hinged knee, we've got collars, we've got advances in endoprosthetic engineering, and that's why our limb salvage rates have gone up. And we are now able to salvage 90% of all sarcomas, which were in the past treated with amputation. So the amputation rates have gone down. Limb salvage rates have really come up in the last sort of 5 decades. That's what has changed. And the key decade for all that to change was the late 80s, early 90s, really. Reconstructions, we can reconstruct, we can elect not to reconstruct anything. So you could, for example, take somebody's pelvis out and leave them with a hanging head, which is essentially a reverse girdle stone. So no pelvis, just a femur hanging against a mesh on the peritoneum, and it just acts as a piston. You could also reconstruct with biological reconstruction, or allograft or an autograft with fibulars. You can get your plastic surgeons. Allografts have a high rate of infection, but the newer allografts are much more promising. You can do endoprosthesis. You can even fuse joints, and there are ways of fusing it. So I'm not going to go in very much detail about the techniques, but at the level of the exam, you can talk about biological reconstruction and obviously endoprosthetic reconstruction or no reconstruction. So just an example of how these implants function. I don't know if the video will play because I've just transferred this from my old laptop. No, it doesn't. Anyway, so I think, yeah, what we've done is we've shown really good survival with some up-to-date implants. We've now moved ahead of Stanmore. Stanmore used to be the mainstay of endoprosthesis in the UK, but sadly, it's going out of the market. So we now have better solutions than Stanmore, even showing better survival than what we had a decade ago. And all we're looking at, you can see this nice incorporation of the collars. So we're looking at biological fixation of these implants that gives really good fixation, prevents loosening, and is improving survival of the endoprosthesis in the long run. Infection does seem to be a problem, especially around the pelvis. You've got a 20% infection rate. In the upper limb, not so much. The humerus seems to fare much better, probably because of better blood supply. The proximal tibia still is a problem, and that's why we treat a lot of proximal tibias with our orthoplastic support, and we try and get some gastrocnemius across as an example of a proximal tibia, which is well covered by gastroplasty. standard of care now. When we do proximal tibias, we try and cover them with gastro flaps. And you can see that, yeah, they get good function. They do get some extensive lag, but an extensive mechanism that because they are eventually able to get relative function. I'm sorry, the video is not going to play again. We do use our orthoplastic support in reconstructing sort of, areas where we need vascularized fibulas. This was not exactly a vascularized fibula. This is somebody with a Ewing sarcoma of the distal fibula, which was taken away, and then the fibula was turned down with a skin paddle to give not only coverage on that side, but also provide with a stable ankle joint. And the ankle was reconstructed sort of with syndesmosis screws. They had really good function after the operation. There's again an adamantinoma. We sometimes use more radical techniques. So adamantinoma had an intercalary resection, and then we used our limb recon service to provide us with that solution and use bone transport. Luckily, adamantinomas do not need systemic chemotherapy. You would worry to do that sort of a treatment with somebody with osteosarcoma, because then your regen rate would not be good. Anyway, that technique also has a space in sort of reconstruction. That's sort of the bone united after months and months of lengthening. Another example of sort of a really distal tumor, which was transported over a nail, and the ankle eventually ended up being fused with an ankle through ankle nail, hindfoot nail. So what has improved? Well, nothing much. We are still looking at about 56% 10-year survival in terms of oncological outcomes. What has improved is our ability to salvage limbs in terms of what we can do in terms of orthopedic techniques and how we build. There are certain lights at the end of the tunnel. We've got some signal receptors and intracellular pathways that we can target, and that's why the whole genome sequence is being sort of built as an international database where new gene therapies are going to come in. We have now radiotherapy with less collateral damage, including proton therapy. Carbon ion therapy is currently not available in the UK. It's available in Japan and some of the neighboring countries. Hopefully, we will have a center in Europe. There are only about 5 centers in Europe that do proton therapy. One is currently in Manchester. The second one is being set up in London. I'm not sure if it's operational yet. But yeah, it will definitely lead to better radiotherapy. One of the new drugs, which is now added to osteosarcoma chemotherapy regime, is this derivative of of a bacteria that used to give us TB. And one of the derivatives of that is now cell signaling, sort of a sensitizing agent to macrophages and cytokine pathways to try and kill osteosarcoma osteoblasts. And that's now part of the pediatric regime for neoadjuvant treatment of osteosarcoma. The other thing is denosumab. You all remember the rank ligand pathway, which is one of the pathways you need to be able to draw for the FRCS exams. This is a drug that is a competitive receptor of the rank ligand receptor on the osteoclast, which leads to pausing the osteoclast, stopping them from destroying cells. It is now used in treating giant cell tumor of bone. So that's a tandem, quantum shift in the treatment of giant cell tumors over the last almost decade now, because it was licensed in 2014 for treating giant cell tumor of bone, and it has helped us massively. So those are the examples of drugs that are coming up. So coming to the end, and I'm aware that we are just at, the clock has struck 8. Nothing is, I know we keep talking about 56% survival and nothing is improved. We're still looking at a bright future, so it's not a dead end. We're still sort of looking at new treatments, so future looks bright. There are effective treatments coming up. There are effective implants coming up. There are techniques that are improving to improve patient outcomes in terms of function. There are obviously, adaptation prosthesis that are improving, which is obviously a separate topic altogether. So there are still horrors out there that we need to manage. However, I think a sarcoma surgeon needs to be alert of all the horrors. Thorough assessment is the key to diagnosis. There are no shortcuts. You need to have the right tools to manage these patients. You can't handle them with, hormone implants. You need to have the right diagnostic tools. You need to have the right treatment tools, and you need to have the right colleagues. And you need to have the right advice. So thank you so much. And if there are any questions,
ask about, do you do NGS panel on each patient with soft tissue sarcoma?
yes. So that's the national guideline now for the. So it's WGS, by the way, whole genome sequencing. And yes, the national guidelines are that we need to be doing fresh frozen samples on all soft sarcomas. However, if you look at the actual results, I think up to 20% and 40%. I shouldn't have said that. Is there someone here listening?
Another question is about any experience with the 3D printed implants for pelvic reconstructions, and if yes, what are your preferred polymers? Very specific questions.
Okay, so 3D printed implants is different. So in the UK, 3D printed implants are not as commonly used as we do 3D printed digs. So we do 3D printed digs, which is a bit like PSI in arthroplasty to give us margins. But yes, you can use the same technology to actually print an implant that goes right in the defect that you've created. And that could be done in arthroplasty or in sarcomas. So currently the companies that we work with, they made it with surface printed titanium alloys. So it's titanium mainly that these are constructed with. Does that answer your question? If, for example, I take somebody's part of the pelvis out, there'll be a titanium implant that will go in there, and then the surface which interacts with the bone is, it's a micro. It's called the 3D pole texture that's treated with, which is not exactly tantalum, but it is supposed to resemble very close to tantalum. What tantalum is.
Okay, and that was the last questions here in the chat. So any burning questions? So if someone would like to ask any questions, we are happy to answer now. You can unmute yourself and speak if you
Sorry,
like.
I just put a question now. It's regarding what's the for FRCS exam. If I got a bone cyst or osteochondroma or something simple, I'm quite sure of the diagnosis. Is my answer that I still need to discuss it with the tumor and refer it to the sarcoma MDT, or just say that I'm happy with this, I'm just gonna follow up the patient in the clinic?
So it depends on obviously what you're looking. If you're describing a purely benign looking bone cystic lesion, right? So then your defense. So how you describe it is important. So you will describe your X-ray findings. You will say my top defense is benign. However, this could be infection. Infection is one of the defenses you need to mention, probably for a cystic lesion. You might say metabolic bone disease, right? Like Brown's tumor, if it's a cystic lesion. And then you say it could be a malignancy, but my differential, you've already given your top differential. You said this is a benign. If, for example, if it's a unicameral cyst and you've got a fallen, fragment sign, then that's fine. You say this is my top differential. This is what I think this is. But my list of differentials would be X, Y, Z. You don't need to go through malignant. You don't need to go through all of the malignant things, right? And that's how you will go. Does that answer your question?
No, apologies. Sorry. My question is that we reached the diagnosis and it's a bone cyst and it's non-operative treatments. And we reached the diagnosis already. Do I still need to refer this patient for local MDT and tumor and oncology, or no? Because in real life, we don't do this.
So no, not all benign bone cysts need to be referred. Not benign disease. Unless you're worried that they need further investigations, or you're worried about your diagnosis. Any other questions?
Mr. Siddiqui, I have a question, please.
Yep.
Sure, go on.
Yeah, thanks. In terms of the osteosarcoma management, we talk about neoadjuvant chemo, then surgery, then again adjuvant chemotherapy. So is there a time lag between the new adjuvant and the surgery?
Yes. So normally you would have minimum 2 to 3 weeks. You know, minimum of 2 to 3 weeks.
Okay.
Because you allow the patient to recover from the chemotherapy. You wait for the cell counts to come back to normal.
Right.
And then, but normally you would be waiting for 4 to 6 weeks. But a minimum of 2 to 3 weeks would be required. You can't just have a chemotherapy cycle and operate on them next week.
Okay.
Are you still finding it clear? Hear me?
It's breaking up a bit.
Yeah, that's right.
I don't know why, but
I think it's good when you are close to the.
okay. Maybe I have an old laptop.
Okay, so if there is no more questions, we can start Viva.
We have some poll questions actually. Shall I just quickly pop those up for people?
Sure, yeah.
Okay, we'll just give people a couple of minutes to answer those. And just to note, the image that my colleague is kindly sharing goes with question 4. Okay, just another 60 seconds. Okay, sorry. Someone keeps ending the poll, so I'm not going to run it for a third time. So I think it's best that I just share the results that I've got here. And if you can kindly talk through the answers, please, Heather. Sorry, we can't hear you.
Sorry, yeah. Sorry, I was muted. Can you hear me now?
We can.
So I can see the results on my screen, which is most of the people have answered. Only 6 people have answered. Is that correct? 11 people have answered. Is that because people kept
Yeah,
ending
no,
the
I
poll?
think more people are answering, but the poll kept ending for some reason. So I don't want to launch it for a third time, otherwise we'll be here all night. So if
Anyway,
we just,
quickly,
we can just,
out of the answers that I can see, I'm
Okay.
sure the majority would have answered it right, but out of the answers that I can see, most people have said have selected option 8, which is 16 centers in England. If you read that statement correctly, for primary malignant bone tumors, there are only 4 centers, actually 5 centers for primary malignant bone tumors, plus 16 for primary soft tissue sarcoma. That's incorrect. The correct answer on that is a smaller number of centers out there for primary malignant bone tumors as compared to, so the correct answer is B. So again, the poll results are a bit frozen.
so if you just use the, you see the scrolling bar
Yeah.
to the right hand
So all
side
of
of
the
that
correct
box and
poll
scroll
answers,
down.
most of the people have got that right. Casting reconstructions are not core members, so that's fine. Radiation oncologists are core members, so whoever's answered that is incorrect. Following so again, it's frozen. I can't see all of your. Can you read out the results to me?
Yeah, sure. So for question, so for question 3, following are all clinical and radiographic features of aggressive behaviour of benign cartilaginous, I can't even pronounce these words, lesions except eccentric location.
In the medicine is the correct answer. So periosteal reaction is eccentric location in the bone is the answer, which is a benign lesion. Okay. What's the next one?
So it's the 13-year-old female attends your office with pain in her left knee.
What have people answered?
Ewing sarcoma, Ewing sarcoma to 67%, chondrosarcoma 33%, myeloma 0, all the rest was 0 actually. So most people went for the Ewing sarcoma.
I can't see the results. Yeah, so I think there's a tricky one because a typical laminated periosteal reaction, and it's got these large cystic areas. What's the other thing that's common bone pathology besides Ewing? Osteo. And then have you seen any, do you remember subtypes of osteosarcoma? Anything that has got a lot of cysts in it? Anyone heard of a telangiectatic osteosarcoma?
Yes, it is very similar to aneurysmal bone cyst. You always put it in the differential.
Exactly. So you see exactly like an aneurysmal bone cyst on your MRI scan.